Welcome, and we're really delighted to host this event today. It might be a little challenging too, but very differently to the Aged Care Report, Hal. And this is the second Better Health Forum. We've done a couple of things differently to the last one. You were really clear you wanted more time to network, so hence this morning there was a lot of chatter, and we'll try to build in as much chatter time as we can so you can catch up with each other. And as Jackie Garton-Smith reminded me, it's much better to see people face to face than by video conference, so please enjoy the time that's available to you. And we really just see this event as a contribution to you to think about the future and where we see the intersections across health, primary health, chronic disease and so forth, all coming together. So I think Hal will give us some definite food for thought. I'd firstly like to acknowledge that we are on Noongar country, and I would also, in particular, like to acknowledge any traditional owners that are in the room here today, as well as pay our respects to both the elders past, present and emerging. We were going to have Professor Rhonda Marriott do the welcome to country today, but unfortunately Rhonda is unwell with asthma. Interestingly enough, Sydney's got an asthma issue at the minute with all the smog, but Perth hasn't. But anyway, Rhonda sends her kind regards. We of course see that Aboriginal health is somewhat central to the conversations that we're about to have today. So, in introducing Hal, I'm really delighted and thank you for making the little bit of travel from the East Coast to Perth. But Hal is a research fellow at the Grattan Institute, and many of you will have read Grattan Institute's reports previously. And Emma, I won't say it, Hal. Anyway. Latrobe, and has held senior advisor positions in government and has a catalogue, I can't believe this, of more than 150 books, articles and reports and conference papers. I've never kept count. I doubt that I'd get anywhere near that number. So comes with a lot of expertise. Hal has worked obviously closely with Stephen Duckett, but the important piece is that Hal is actually a thought leader and an influencer around primary care in Australia and the role that primary health networks can play. Many of you will know we talk to integration a lot. What does integration mean? Well, it means a different thing to every person in this room. And I think having a shared understanding of what we all mean by integration and what that means for the people that we're here to serve is really going to be important to the system as we go forward. So how do we improve integration across the health system, both from our perspective to improve equitable access to care, but also improve health outcomes? So, on that note, I'm going to hand over to you, Hal.
Let me firstly say that it's a great pleasure to be here, and I also want to join with Leanne in acknowledging the traditional owners, past, present and emerging. I had the interesting experience in my own bit of the world, which is a lovely little town that I live in part-time, called Daylesford, which is just outside of Melbourne, and the people there are the Jaja Wurrung Indigenous people, and they have a long history there, and I had the interesting experience of being part of a history lesson tutorial on the local Indigenous population and how they'd lived prior to European settlement. And I just realised doing that there's so little of that actually happens in Australia, that we really don't really understand the nature of the communities that were there before white settlement, before a European settlement. So I encourage anybody who has the opportunity to do that for your own local area to do it. I found it fascinating. I thought it was really a very interesting thing to do. I'd also like to thank WAFA for inviting me to do this presentation. And I've done a few things in Western Australia. I grew up in Western Australia, so I know WA reasonably well. So I'm always pleased to be back here. Although I have to agree with Leanne that I was a bit shocked at the weather yesterday. So and it was 33 in Melbourne, so I was very deeply distressed at that point. The place that I these days spend time is the Grattan Institute, and Grattan's been terrific for me because it's allowed me to pursue the research interests that I have. And Grattan's approach to the world is that it tries to do research which is independent, rigorous and practical. And so today I'm going to try and talk a little bit about the primary care policy landscape, but I want to try to get to some practical suggestions for where we might deal with some of the major issues that I'll identify. As Leanne said, we're at the moment we're experiencing a moment in time where there are significant numbers of reports which are coming out. The Aged Care Royal Commission was yesterday's, and the mental health one was the day before. And there's also a Disability Royal Commission, which is a standing Royal Commission for the next 5 years. And there's those of you who may know, Victoria has a Royal Commission on Mental Health going as well at the moment. So there's obviously a lot of interest in what might be called long-term care and people with complex needs living in the community. And the primary care system intersects with that long-term care set of issues. And today I'm really going to look at that set of issues in relation to primary care and what the challenges are, and make some suggestions about how we might progress this set of issues. So where I'm going to go is firstly talk a little about the changing context and and what we might need to do into the future, and then what's been done so far. And I want to split primary care into a couple of different parts, and because it's a complex set of issues that we have to address, and I want to try and deal with why those complex issues are there by differentiating between different types of problem. And then I want to go to where are we going and introduce a new idea that is. It's been around for a little while, but it needs to be contextualised for Australia, which is the idea of integrated health groups. And then talk a bit about some of the issues in trying to address this concept of integrated health groups. So first thing to say is that we're probably at a moment where there is a lot of interest in change. There's a recognition that there are significant problems. Those of you who've had the chance to look at the aged care report will realise what is going on in relation to our challenges in dealing with older people. The disability work that's been done in the past illustrates the challenges that are there for people with complex needs. The mental health issues are very significant. We're probably at a moment where we're seeing a lot of effort thinking about these challenges, these complex needs in the community. Let me take you through why this set of issues has been emerging. Over the last 100 years or so, we've had a significant change in the nature of health in the community. 100 years ago, we lived to be about 50, and then the infant mortality rate was, to give you a sense of it, was about 10%. So actually it was between 10 and 20%. It was at the turn of the century, about 140 infants died in the first year of life per 1,000 infants born. And if you think about that and the change which has occurred in that period of time, in the last 100 years, that's a very significant change in the nature of health outcomes, which means that infectious diseases have mainly been gone. As many people died of tuberculosis in the 1800s as die of all causes today. One disease. So we've seen a very significant change in 100 years or so in terms of the health of the community. Today, 90% of people will die from a chronic disease. Most people will die in their 80s, 70s and 80s, 90s. So we've had a 30-year increase in life expectancy. So that means that we've got a very different sort of healthcare system than what we had 100 years ago. At the same time, we've seen, of course, enormous changes in social conditions and expectations. So the whole nature of the way we live has changed. And so we've seen a dramatic increase in the rate of women's participation in the workforce. We've seen a hugely more mobile population. Many people live a long way away from the communities that they grew up in. We've seen an enormous change in the way work patterns have occurred. We've moved towards a world which is heavily focused on services industries, technology industries, moving away from manufacturing. All that has meant that the nature of how we provide care for communities has changed. Then most people like me who do this for a living talk about the notion of essentially the compensatory welfare state. So what we've moved towards is, in order to allow all that productivity to occur and these changes and your lifestyles, our lifestyles to emerge, we've had to change the nature of the way we look after the work that families used to do in the past. So childcare has moved out of being something that families exclusively do. Aged care has moved away from something that families exclusively do. The support for people with chronic illness has moved away from something that families exclusively do. If we talked about pre-Second World War, essentially the system was families and institutional care for people with complex needs. We've increasingly moved to a world where we have seen an expansion of the demand for services in the formal community sector. And so as informal care has reduced, because we've wanted a more productive workforce, and women working in the workforce in particular, we've moved towards a system where we provide those services that families did in the community through the formal workforce. The other thing that's happened is people have looked at institutional care, particularly after the Second World War, and said, well, we don't like that very much. So mental health, disability in particular, but increasingly aged care as well. I was talking to Leanne beforehand, and she assures me that she does not want to go into a nursing home. And I'm guessing that if I asked you which of you is keen to go into residential care, there wouldn't be a lot of takers. And so what we want is support at home and in the community to keep us living the way we want to live and to doing the things that we want to do, even in the period where we're dying. In that period when we're dying, we would like to have support services for ourselves and our families which allow us to continue to live in a way which is what we talk about as being a high quality of life. And it's interesting if you look at the Disability Act and compare it to the Aged Care Act. The Disability Act has moved in that direction very significantly with the NDIS, and the system itself has problems with implementation, but it's a huge change which is occurring. So it would inevitably be the case that implementation issues would come there. It's tripling in size in terms of spending alone. You think about having to find a workforce for that, finding the management systems, the training and so on and so forth. So the implementation issues, although they need to be addressed, are understandable. So you have to look at the design of the system. What the design of the disability system is about, its principal focus is on providing, and I quote from the Act, the necessary and sufficient, reasonable and necessary means to support people in the community, and so they can participate in the economic and social life of the community. The Aged Care Act, if you read it, is all about providing quality care. It doesn't say much about people participating in the community or supporting people to do that. And the Aged Care Act is now 15 or 20 years out of date in terms of its overall approach. And we're seeing that reflected in the Royal Commission's report yesterday. The mental health is the same. It's a schmozzle in Australia at the moment, notwithstanding the fact that primary care and PHNs are doing a good job in trying to move in that direction, to try and fix these issues. The reality is we don't have a coherent mental health policy in Australia at the moment. And we've got fragmented services all over the place. The reality in terms of the slide I've got up there is that we have seen massively increased demand for these services for more complex people, so people with much more complex needs in the community. And that's been an enormous expansion. You're all here today. I'm going to guess that if we had this meeting 60 or 70 years ago, there would be 10% of you in the room, because all your services have basically emerged. Those of you who work in the community sector have emerged in that 60 or 70 year period. That's been an enormous expansion of services which have occurred. I'll come back to that in a minute. The other thing that's there is that we've seen the Commonwealth and the states in Australia both getting into this space in a significant way. Technically, the Commonwealth has responsibility for primary care and the states have responsibility for everything else. And the Commonwealth and the states share responsibility for most of these things. And what actually happens is we have both Commonwealth and the states doing most things in reality. And that creates a really significant set of problems, because that means that actually nobody runs the system at the local level. So we have fragmentation and duplication. Primary health networks, which I've been associated with, I was at one point the senior advisor to Carmen Lawrence when she was health minister. And we started off a process called coordinated care trials to try and address these issues. Now that's 25 years ago. And divisions of general practice emerged at that time. I'll come back to that in a minute. But those issues have been around. We have known these issues for a very long time in terms of the fragmentation and the duplication. And what that results in, and that wouldn't matter if outcomes were good, if everything worked really well. Now, primary care works very well for some people. Essentially, if you've got straightforward conditions and you need an episode of care, a dentist or a GP, then it works pretty well. As soon as you've got really complex conditions, it starts to get messy and we get inefficiency, people's experiences aren't that good, accessing services becomes problematic, and the outcomes are suboptimal. That applies both to people who've got significant health conditions and for people who are at risk of developing significant health conditions, those who've got high levels of risk factors, obesity, alcohol and drug problems and so on. They're messy at the moment in terms of the way that it's organised. So on the positive side, and this is important because the other huge change which of course has occurred has been that we've had a digital revolution which has made a whole lot of things possible which previously in the community weren't so possible. And this has meant that we now have data systems which are infinitely better than they were pre the digital age. We have decision and support systems and pathways which you can access online. You have telehealth remote video arrangements. You can do online administration. You can do online learning. This is radically changing everything. I remember when I first went to Canberra and I walked into the minister's office and they handed me this thing and they said, and I said, "What's this?" And they said, "It's an IBM ThinkPad." And I said, "What's an IBM ThinkPad?" And they said, "It's a thing that allows you to connect with everybody in the Department of Health in Canberra." And I said, "How do we do that?" And they said, "We do that through something called the intranet." And I said, "Really? And how does that work?" And they showed me. And so I then learnt all about email and how to run an email system and so on. And I said, so, thinking ahead, I said, "So what do I have to be careful about doing this?" And they said, "Don't get chained to your inbox." I've been chained to my inbox ever since. And I'm sure you're all chained to your inbox too. And it's so then when I was Dean of Health Sciences at La Trobe, I went completely paperless. And I could go anywhere. And these days, that little iPad that's sitting on the desk there is basically my office. And so that's radically changed the nature of how we can deliver services, how we can think about things and so on. It is true that it's better to be face-to-face, but you don't need to be face-to-face all the time, because you don't have to travel. And all sorts of things have to happen. So we radically have changed the world through the digital environment as well. So the overall set of issues then are, we've seen huge change in the nature of health, huge societal change, and we're seeing technology making a whole lot of things possible that previously weren't possible. That's the context. Let me talk a little bit about the two types of... Now, I fully expect that somebody will point out that there aren't really two types, there are many types, which is why my slide is up there with many different arrows pointing. But essentially, from a functional point of view, from the service delivery point of view, you can think about things as being either relatively straightforward and episodic, having, and I apologise to all the dentists in the room, but having a cavity repaired in a tooth, in which case you don't need a huge amount of coordination and not for me and many of you in the room. I don't need someone to coordinate my care to go to the dentist. I probably need them to prompt me to go every now and then, but I don't need a lot of coordinated care. But if you're an 85-year-old person who has multiple chronic conditions and has got a little bit of cognitive decline, then you probably do need quite a lot of support to get you through the system, particularly if you're having to navigate new sets of arrangements. So we do have, you can see, different types of healthcare functional problems. So we can think about complex care and more straightforward care, and when you need to have coordination and not. Hospital events also can be thought of as complex care, and often the post-acute and the pre-acute phase do need to be coordinated and managed through and into the system. So we need to think about these problems as different types of issues. There are other problems in the healthcare system, other ways of thinking about problems. The problem that we have in the healthcare system then is, if I can go back to that one, is the complex care bit. So primary care works reasonably well for the straightforward care. If you've got a straightforward condition and you're reasonably well and you're pretty competent, you don't need a lot of coordination and you can probably access services reasonably well. The Australian healthcare system works pretty well for those people. It doesn't work well for the complex care. The problem is complex care in Australia. That's what we have to sort out. Mental health, aged care, people with chronic disease, people with alcohol and drug problems, etc. That's the problem. And the problem is there because of that history that we've got. And I'll come back to that history in a second. So there are other problems like inequity, access barriers, sustainability, and so on. And there are particular groups like Indigenous populations and so on which have uniquely important problems that need to be addressed. But I want to concentrate today on the complex care issue and the notion that we've been talking about for 25 years, which is integration and how we try and solve those issues. The problem with complex care at the moment is that it produces higher costs than otherwise would be required, poor experience for people who are using the system, and poor outcomes. I'll just illustrate my poor experience bit with recent experience where I watched and I tried to stay out of it as much as possible. I watched one of my relatives trying to sort out a problem for an elderly relative and trying to navigate the My Aged Care website. And it was chaotic in terms of trying to navigate this. And it involved not having anybody on the end of the telephone who knew how to manage the system, the information being superficial, the responses once the aged care assessment had been done being slow, took a year to get an aged care package, etc., etc. Many of you will have had these experiences. Now, I could replicate those in the mental health system as well, I'm sure. And I'm sure there are issues in the disability system at the moment. If you're talking about chronic disease, coordinating between multiple specialties, GPs, trying to get support services at home at the same time becomes a real challenge. Same with post-acute care. So this is the nature of what we've got. And so if we think about episodic care, what we've got is we can have episodes of prevention, people coming in who are obese or who have high blood pressure and GPs managing that through a whole series of different interventions. We think about acute care episodes, we can think about rehabilitation episodes, and we can think about supportive care, which is what you need when you need an episode of people providing these services. for an episode of care. All of those things can be wrapped up in an episode of care, and that has a defined start and end. The problem is with complex care, often you need all of those things, but on an ongoing basis. So it's not that complex care is any different from episodic care in the bits of care which are actually delivered. It's that they're organised differently. They're put together in a different way, and they require planning, coordination, guidance and support, and they require problem solving, monitoring, review and so on. And it's an ongoing activity for people when they're in that sort of set of circumstances. But it's only relevant for about 20% of the population. So what we tend to have is a system dominated by episodic care instead of complex care. The reality is that when you look at it, about 80% require, the population on any given year just do prevention and episodic care. About 10% have ongoing multidisciplinary care and needs, but they're largely self-managing. Many people manage their own chronic conditions on an ongoing basis. And there's a group which has a much more significant set of needs, and then there's a tiny group at the top, 1% perhaps, who have really intensive needs and who need a lot of support. Often they're dying, those people. Often they're in the last part of their life. The reality is that most of the costs are, of course, in that top 10%. And we move through and look at that sort of a cost diagram. But because most of the people that services see are in the other categories, they are designed for episodic care. And we haven't done well at designing services for complex care. And we have a service system that looks like this. And this has grown like Topsy over many years. And so we have all of this out there in the primary care system. What we want to do is bring these services together in some form of integrated way so that we have integrated care. So that's what I'm going to talk about. So what have we done so far? We haven't quite hit the target yet. We're trying, but so what's happened is we've had a set of initiatives. So we've seen in general practice vocational training and regulation and registration to improve the quality of general practice. This has led to AgPal and accreditation systems and so on. We've seen the development of a training program for general practice. That happened 25 years ago now. I can remember when I showed up in Canberra, I inherited the divisions of general practice program as an advisor. I had responsibility for providing advice about all of everything except hospitals, basically. And so what I discovered was that we had basically a tanker truck full of money that we had to get out the door to set up divisions of general practice and the vocational training program, which we negotiated with the College of General Practitioners. So we did all this to get that going, and that was all about building a partnership with general practice so that we could improve the quality of general practice. Divisions of general practice, vocational training and registration, accreditation, were all part of that. And then we tried to bring in what was called the blended incentive program, and this led to, some of you may never have heard of this, standard weighted patient equivalents, SWAPPIes, which was a way of trying to pay for GPs to have continuity of care. So we paid them, the more they had a patient all to themselves, the more we paid them for that patient. Otherwise they had to split it with other GPs. Anyway, we put that all in place. We ended up with the development subsequently of allied health items. We realised there were no allied health practitioners out there, so we created allied health items in the Medicare schedule. We then created the chronic disease management items. So we created general practice management plans, and so on. Commonwealth state agreements were put in place to try and have a debate about preventing unnecessary hospitalisations. And so we then saw that happen. And right in the middle, we created these regional organisations, which first were divisions of general practice, then Medicare locals, and now primary health networks. So that's the history of it. we've been trying to get to the point of getting some leverage in the system to try and deal with that previous diagram which I had there. And what we now end up doing is spending over $1.5 billion on coordination through chronic disease management, mental health plans, health assessments, service incentives, practice incentives, and primary health networks. So we've got a lot of money being allocated to trying to deal with this set of problems. And there have been recent initiatives in relation to the practice incentives, which now are going to, there's that standard weighted patient equivalent SWAPI index. So we're getting $5 per SWAPI for providing data on 10 indicators, quality indicators. We've seen the recent initiative to introduce an over 70s program for coordination by the Commonwealth, and we've seen the healthcare home trials. And there are a number of other smaller scale initiatives which are out there at the moment. But essentially, people have been going at this for a long time to try and deal with this set of issues. But general practice is still small scale. There's limited staffing, no coordination staffing, no authority for people to actually manage across the system. We've got still limited extended hours coverage, pretty patchy in terms of how that works. And there's there's really a notion that assessment, that coordination is really assessment, referral and report back. It's a referral-based coordination model at the moment, rather than a fully coordinated approach to what's going on. And that's okay for episodic care, but it's not so good for complex care when you've got to have ongoing sets of arrangements. So where to from here is the question. So what's happened? How come we're in this position? We've been going at this for a long time, and what's missing is, I suppose, what I've been concentrating on lately. So I've been doing this for a long time, so I thought, well, we've sort of made progress, but we still have what's the missing bit? And so I think the missing bit is that we haven't thought through how you actually organise that system, that diagram with all those bits and pieces that I showed you, the spaghetti diagram, how you bring that together as a service delivery system. Now, I want to use an analogy, and this is good from the technology point of view. I regularly buy things online these days, and when I do, I go online and I find the thing that I want to buy. The last thing that I wanted to do, I like going kayaking, so I wanted what's called a deck bag for a kayak, which is a little thing that you put on top of your kayak and you put your camera in it, and it straps on. And I couldn't find anything locally, so I thought, right. So I went online and I bought this deck bag, and it comes from the US. I get the deck bag, go online, register my purchase, pay for it online. That takes 15 minutes, 10 minutes. They then tell me that I've done this, send me a confirmation number, tell me when it's being packed in the warehouse, tell me when it's going to the post office in the US, tell me when it's on the plane, tell me when it's got to Australia, tell me when it's got to the post office at my end, which is a little country town, and tell me when I have to pick it up. Right? This is all done beautifully. There's an example of coordination across. Now, the people who are running that, Amazon does not own a post office, does not own a deck bag making manufacturing plant anywhere, does not own the airline that delivers this stuff, does not do any of that. Yet the deck bag gets to me in 5 days. And this is an example of what coordination looks like. And hence my note about technology being a really important enabler of what you can and can't do. Now, healthcare is not the same as buying a deck bag. I accept that and I understand that. But I give you the example of what seamless integration, and the fact is you don't need to own all of those services. What you need to have is a coordination system for pulling that together in some way. How do you do that is the question. So, what's the traditional approach? Well, the traditional approach is what's called corporate vertical integration. I get you all to join my one big corporation. And we could do that in Australia to do better integration of services by, for example, hospital expansion into primary and community care. This would be the hospital demand management program, which some hospitals now do, where the very unfortunate term frequent flyers is managed through the notion of we will have an outreach program to sort out these issues, and we will do hospital demand management doing that. You could do it through the notion of corporate horror. That's vertical integration. That is the acute sector moving into the primary care sector. You could have expansion in the primary and community care sector by bringing in extended care organisations. Bolton Clark, Silver Chain could move into this space and say, right, we will employ lots of GPs and allied health staff and so on, and we will move into the space and we will bring it all together in the one organisation. And that is actually still a real possibility in Australia. They're all, those big organisations, some of you may be from those organisations here today, are kind of looking at where everybody is positioned in the space. That is a possibility that could move in Australia. The other possibility is private corporations, primary healthcare, etc., the major providers. They've largely focused so far on economies of scale to make money by bringing practices together, running a better administration system, and then integrating it with pathology and radiology. And that's how they've improved their... And then they have a return to shareholders as a result of doing that. They haven't really seen an opportunity as being the better management of chronic disease and complex care. That's not where they've gone. They've scaled up in other ways. The other approach which is emerging is the idea of network integration. And this is the Amazon example, where you bring a whole set of services together for a particular purpose and you coordinate them really well to get a really good result for the individuals involved. Now that could occur through bringing services together through allied health, bringing affiliated practices together into cooperatives, consortiums, partnerships or companies. And that would include the sort of thing that you have to sort out if you're going to do that is enough scale for efficiency and effectiveness. So you don't want it to be too small so that you can't actually scale things up and get an allied health team and a nursing team and general practice and so on to work together, but sufficiently small for engagement and mutual trust to still operate between the people participating in the network. You need provider independence to be maintained, because the politics in Australia is that if you start talking about forcing general practice into bigger organisations and so on, you're in a lot of trouble. And similarly with allied health and everybody else. I'm sure if I said to all of you, I want you all to merge into one organisation from all of your existing organisations, there would be unhappiness and I would be fighting with you for the next 5 years and I still wouldn't get anywhere. So you need to think of an alternative way of bringing people together in the same sense as Amazon doesn't own the deck bag manufacturing, the post office, the airline or anything else, but it brings them together in an organised way. So they can remain independent providers. You need to think about focusing on prevention and complex care, not the simple stuff, because they can continue to do that. You need to focus on enhanced coordination. The whole thing is about coordination working really well for people. That's the so-called patient-centred approach to what you're trying to do. And it has to have benefits in better access, experience and outcomes for people. And it has to have benefits for funders through reductions in avoidable high care costs, and benefits to providers through funding, incentives, clearer roles and responsibilities and better support. So there has to be a win-win in this kind of world. So that's what you might think of. So then in the last 10 minutes or so before morning tea, let me talk about an approach. So I want to draw a line there and say that's the issue, and here are some things that you might want to think about. And now I want to suggest a particular approach to doing it, which we've been working on, which we're calling integrated health groups. So integrated health groups, and this is by way of how you could do this, and we can discuss this some more. So you could take populations of 30,000 plus. This is based on an analysis of the scale that you need And that means that you would end up, if you take the 20% of people who have complex care needs, that means you have, for 30,000, you have 6,000 who have complex care needs, and then you have in that 1% of that, so you have 300 to 500 people who've got really, really significant needs. And that gives you a scale factor where you can then build an allied health team, a set of general practitioners, pharmacists, and so on to come together to try and deal with that population group. You then need to be able to provide the services, which are listed there. You need to be able to do extended hours, home care, rapid response. This is all pointless if you can't do that. If Amazon says, yes, you can have your deck bag, but it's going to take you 6 months to get it, guess what? They go broke. So unless your service can deliver rapid response at home, in the community, and do this really well, it's not going to be worth it. You have to have that as the test against it. This is, older person who you know very well has an exacerbation of the episode an exacerbation of their respiratory distress, which can be managed at home by people who know that person. But if they don't know that person and they ring 000, what's going to happen? Call an ambulance, right? And they end up in emergency. And they manage for 6 hours for their respiratory distress, and then they go home. Correct? So if you don't have this kind of approach, if you can't deliver this, then it's not going to work. Plus the ongoing coordination and the prevention and so on and so forth. But we haven't got a competent system that can do that at the moment. So what the approach then says is, well, we need an enhanced shared infrastructure for screening, minor procedures and urgent care and telehealth as well to go with that. So you have to set up the capacity in this set of arrangements. So how do you do that? Well, one of the things that you need is somebody who's going to have to pursue this, and PHNs are probably the logical player because they don't deliver services. So they don't have a competitive problem in terms of doing that. The second thing is you need to see the separate development management infrastructure funding. So you need some funding to make this go. You need to see that in the longer term, commissioning could go to networks rather than to individual agencies. And you could see in the end Medicare funding for complex care and prevention being tied to networks. And also networks could do business support services, recruitment, training, development, and so on. That's what they could do. So they should achieve, for patients with complex conditions, much better outcomes through a better coordinated service. They should achieve for patients with risk factors a reduction in risk factors. And they should achieve for practices, for providers, for services, greater efficiency and sustainability, greater capacity to bid for service contracts and improve quality. So in New Zealand, for example, when the New Zealand government changed in the 80s and Roger Clark came in as Treasurer, they went to a radical competitive environment. And in that set of circumstances, general practices immediately banded together into networks, into what were called independent practitioner associations, because they could see that they weren't going to get access to the competitive funding unless they had broader organisations which were capable of delivering that. So that was a burning platform in New Zealand which created that. It's happening in the UK through primary care networks, which are similar to this concept, and in the US through what are called accountable care organisations. So this idea is emerging as a way to try and solve these problems. The approach could be done with prevention and subacute care, the elements that I've talked about earlier, and then a series of these being developed across the country. You have 31 PHNs. You could see 500 of these networks developing in some form or another, and that becomes then the way of organising services, bringing services together. As I said, it's being done in other countries. Australia's still lagging, but a lot of the elements are in place. So if I'd been trying to run this concept 25 years ago, it would have been hopeless because we didn't have a competent structure in the middle. PHN's now developed to the point where they have a significant capacity to support this sort of development. We have commissioned funding. We have the Medicare chronic disease management funding arrangements, the PIP arrangements. We have health pathways, digital platforms. Lots of the digital technology is now emerging as being possible. The data systems are emerging as being possible. So now is the time to start having these discussions, to start seeing, well, what's possible in this space. But theory is easy, action is harder. So we have the theoretical complaint department here, and I'm sure that some of you will point out the challenges in a minute when we get to it. So let me talk a little bit about where I think we're at. So I think we're at the point of having a discussion about this. I don't think we're at the point of saying here is the definitive, absolutely clear solution to the problem. But I am confident that unless we do think about organising services at the local level into more coherent groups which have responsibility for delivering services to those people with complex needs, we will continue to have this discussion, and there will continue to be royal commissions, and we'll continue to be outraged by what's going on for people with complex needs. So in terms of groups then, I've pointed out the elements that you need. The most important thing that has to happen is that you have to recognise the problem and build stakeholder commitment focused on sorting out these issues. What we've had is a history of piecemeal, ad hoc, local workarounds to dodge difficult issues. So everybody's got some solutions to these problems, but they are piecemeal, and I am still amazed at how many people are dealing with coordination with fax machines, right? Where you're still getting stuff being sent by fax. I am amazed at how nobody is accountable for a person with complex care needs managing their way through the service system. It's just astonishing, really, that it sort of is a handover system to everybody. So when it goes wrong, they're all standing around going, not me, right? So that doesn't seem to me to be a sensible set of arrangements. So we have to avoid these ad hoc arrangements. So that means you have to start having a discussion about, well, what does a systemic approach to this stuff look like? And that means saying things like, well, what are the groups of providers? How will we organise them? By geography? By enrolment? How will we start to get them together? Then how do we get them to develop agreement about a systemic approach to guide and test change? Because we're probably going to have to work our way through some of this. It's critical that you have agreement and that this is formalised. The UK experience was that they didn't do enough work on sorting out the agreements and getting people to actually agree on what they were taking part in and what the elements of that agreement would be like. And then it's probably the case that we need to have an approach which applies locally so that people collaborate to get broader Commonwealth and state commitment. Why do I say that? Well, I think it's the case that we're in a space where we have to see both a bottom-up approach to trying to deal with this and a top-down approach. I think if we wait, the Commonwealth, I work for the Commonwealth and many of my friends work in the Commonwealth, but they're not very good at running things, is the reality. I'm not sure how good the West Australian state government is at running things. I haven't had enough to do with them lately. I'm more familiar with Victoria. State governments tend to be better at the dirty, awful, nasty business of actually having to negotiate their way through, the realities of a service system, dealing with industrial agreements, dealing with stroppy professionals who don't want to change, and all the usual toing and froing which goes on. Commonwealth is just generally hopeless at that. And so what it does is it creates big policy pronouncements and big funding systems and big data systems and big websites, and then they founder on the actual realities of delivering services on the ground. Those of you who are interested in this from an academic perspective, there's a fantastic book which was written a long time ago called How the Dreams of Washington Were Dashed on the Streets of Oakland. And it's written by Pressman and Wildowski. And it's this business of when you get central government trying to design everything down to how many pencils you can spend. And in the case of how many 54 performance indicators primary healthcare networks have. This is 52 too many. So the Commonwealth is not the right solution to running services. It needs an intermediary on the ground to doing this. And you need to see service in this messy primary care system. You need to see services coming together in a new form. So my message today then is that you have to apply the approach locally and collaborate, and then work with state and Commonwealth governments to do this. So it's a stepped approach. There's not a perfect solution at the moment. And the issue now is that many of the elements are in place, but it does require the development of the actual organisation of services at the local level. And my 4-minute warning has just gone up, and I'm actually finished. So thank you very much.